Thank you everyone for being patient. Hello, good evening, and thank you for being here to join me in doing this Medicare Basics Zoom presentation. And I have done many presentations for the Stanford Health Library on Medicare, and unfortunately this is my first Zoom one. I usually am in person, and we did run into a bunch of technical difficulties, so I do apologize. But I do hope that I will be able to share with you some good information to help you have a better understanding and answer some of the questions you must have as new to Medicare beneficiaries. So with that, if I can, I don't know if I'm controlling my screen or the moderator is.
Marla, I will advance your slides.
Excellent. So please advance. Great. So tonight we're going to go through a lot of material. Hopefully I can get through all of it. Honestly, when we look at the things I'm going to talk about, each of these things could really be a complete presentation in itself. But since we don't have that much time, I'm going to try and share with you some of the most basic information that you would want to know about as a new beneficiary to Medicare. So we're going to start with the first step of becoming a Medicare beneficiary, which is enrollment, and talk about that a bit. And then we're going to dive into talking about the various parts of Medicare, A, B, C, and D, and we'll look at what the benefits are, and we'll consider the choices that you have with respect to coverage, and we'll look at the costs of Medicare as well, because just like all health insurance, unfortunately, Medicare does have costs, so we'll take a look at those. And then I want to touch on retiree plans, because there may well be a number of you who are listening to this webinar who do have that as an option. And I want to go over a little bit about how retiree plans relate to Medicare, how they interact, whether they coordinate or don't coordinate. And then finally, I'm going to finish up talking about another enrollment period topic, and this is about two different open enrollment periods, which are enrollment periods where people have the opportunity to make changes to, the Medicare coverage that they have. Okay, so welcome to Medicare. Here we go. I'm sure, as all of you know, that Medicare is our country's health insurance program for people who are over, say, 65 and older. And it also is a program that is available to certain individuals who are under the age of 65 who have qualified for disability. And we'll talk about that as we go on. Next slide, please. So in order to talk about Medicare and to talk about enrollment, we need to know what there is to enroll in, what Medicare consists of. So the parts of Medicare are on this little slide, and we have 4 parts of Medicare: Part A, B, C, and D. And Part A and B are commonly known as Original Medicare for a very original reason, which is that that's what we had in 1965 when Medicare started. Those were the only parts of Medicare we had. And today, those parts of Medicare still exist, and they really form the foundation of our Medicare benefits. So Part A is your hospital insurance, Part B, your medical insurance. When we say hospital insurance, we're talking about those services which are medically necessary for your care when you're admitted as an inpatient in a hospital. And that is true with the exception of your doctors, which are always covered under Part B, your medical insurance. So wherever you see your doctors, Part B is what pertains to their being covered for you. And Part B, we're talking about all the medically necessary services that you would receive on an outpatient basis. In 1997, Congress decided to give us another choice of parts and added Part C to Medicare, which we know today is Medicare Advantage. and adding another part gave us more to think about. Whoops, you're going back, not through. And gave us more to think about because it gave us another way to get our Part A and B coverage through private providers that have contracted to provide these plans with Medicare. And I always say this because for me, there's always a lot of confusion, and we'll look at the difference between original Medicare and Medicare Advantage as we go through this. But when Part C started, it was actually called Medicare plus Choice. And for me, that really kind of crystallized it a little bit because you have to have Part A and B, your original Medicare, and then you can choose Part C as a way to get that coverage. So you have Medicare plus Choice. But they didn't ask me, they decided to change the name. And I suspect that some of that is about the fact that these particular plans can also provide some benefits that Medicare doesn't normally provide. Okay, and finally, Part D. And Part D was something that came into being in 2003, and it didn't take effect until 2006. So in 1997, Medicare Advantage plans didn't have drug coverage, and original Medicare doesn't provide for drug coverage. So it was really with this beginning of the drug plan that took effect in 2006 that we had coverage for our prescription medications, and that Part C plans began to incorporate that into their plans. And now today, generally, most Medicare Advantage plans will have Part D coverage included within the plan. Next slide. So enrollment. All right, so there are two important enrollment periods that we need to look at. First of all, the initial enrollment period. So if you are turning 65, you have an initial enrollment period, and that period is one that is 7 months long. It begins 3 months before your 65th birthday month, goes through your birthday month, and into the 3 months after your birthday month. And you can sign up for Medicare, you can enroll in Medicare during any of those months, but when you enroll will determine when your coverage starts. So it's really important that you know when you're going to need that coverage to start so that it starts at the right time. And this is how it works. So if you enroll in the 3 months before, your coverage will start on the first day of your birthday month. If you enroll in your birthday month, then your coverage is going to start the following month. And then as you move into the 3 months after your birthday month, in the first month after your birthday month, your coverage is going to move out 2 months from that enrollment time. And when you talk about the second and third months after your birthday month, you are going to find that your coverage starts 3 months out from whichever of those two enrollment months you've picked. So you really start to stretch out when your coverage begins, and it's really important to know when you need to have that coverage begin so that you don't get caught without coverage. There are people who are automatically enrolled in Medicare. There are two groups. And before I say that, I want to say it's really important to realize that you have to take steps normally to enroll in Medicare. There's no big announcement usually saying, hey, you're 65, go do this. You need to know that you need to take action to enroll. But there are two groups of people that will have an automatic enrollment in Medicare. And these individuals are, first of all, people who are collecting Social Security benefits, Social Security retirement benefits, and they are under the age of 65. So you can start your Social Security retirement benefits early at 62, and you can start them as late as age 70. When you start at age 62, you're taking your benefits early. They're not as large as they're going to be when you reach full retirement. And anyone who enrolls and is getting these benefits at age 62, 63, or 64, they will automatically, when they turn 65 on that birthday month, be enrolled into Medicare automatically. The other group that is enrolled automatically are individuals who are receiving Social Security disability income, SSDI, individuals who are under the age of 65 who qualified for these SSDI benefits based on a disability that met Social Security's definition and determination. And for those individuals, when they have collected those benefits for a period of 24 months, in the 25th month of their SSDI benefits, they will be automatically enrolled in Medicare. So those are the two groups that get automatically enrolled. Now, it is important, nope, not yet. I know you want me to hurry up, but I'm talking as fast as I can, sorry. So now I lost track. So it's really important to sign up during your initial enrollment period, unless you have the right to delay that enrollment, because if you don't, you will have consequences, you will have penalties. So there are people who can delay enrollment in Part B and actually even in Part A. I could not maintain the connection there. So we were talking about the special enrollment period, and for people who continue to work and have employer coverage, group health coverage with an employer of 20 or more employees, that they can wait and they can enroll later when either their employment or their coverage ends, whichever occurs first. They will have an 8-month period, a special enrollment period, within which they can enroll in Medicare. And the important thing to know in this situation, however, is that the Part D coverage, the drug coverage, you only have 63 days to enroll in a Part D plan when that employment or employer coverage ends, or you will find yourself with a penalty and having to wait to enroll in Part D. So 8 months to enroll in Part B, also in Part A if you haven't enrolled in Part A yet. Most people do enroll in Part A when they turn 65 or whenever, because they don't have to pay for it. They get premium free Part A because they've paid into FICA for all the years they've been working. And so a lot of people do that. There is a caveat to that. If you're an individual who is in an employer group health plan, and that group health plan is one with an HSA account, a health savings account, you really cannot enroll in any part of Medicare until you don't have that coverage, because you will find that you can't contribute to the HSA anymore. Your employer can't contribute to the HSA anymore. And if you continue to do that, then you will have a tax penalty. So that's the one situation where you definitely would not want to enroll in Part A and just have it be there. So when you have employer coverage, it is primary in this situation. If it's 20 or more employees and you have this coverage, it's primary should you enroll, if you should happen to enroll in any part of Medicare. And I also wanted to comment that when you're signing up for Medicare, you can get Medicare on a spouse's record if you don't have enough credits to get the free Part A, because for your Part A premium to be free, you need to have 40 quarters of having paid into the FICA taxes, and otherwise you would have to pay something for Part A. So if you have a spouse, you can sign up for Medicare on their record. And also in these situations with the SEP, if you're on a spouse's employer group health plan, you you have that same SEP tied to when they are losing their coverage or leaving employment. Most important thing, special enrollment period, it has to be based on current active employment, the health coverage, and 20 or more employees with the employer group health plan for you to delay. Okay. And then I was going to point out that COBRA and retiree plans are not current employer coverage. So if you were to take COBRA when employment ended and you were eligible for Medicare, you could not wait until COBRA ended to sign up for your Medicare because you still only have an 8-month special enrollment period. So, and COBRA is complicated because COBRA is always going to be secondary to Medicare. And the rule is that if you have Medicare before you become eligible for COBRA, you can sign up for COBRA as a secondary coverage. If you don't have any Medicare before you are eligible for COBRA, your COBRA is generally going to end when you become eligible for Medicare, and you won't be able to use it as a secondary coverage. And it's concerning because a lot of people get confused about COBRA, and they think that because it's basically the policy they had when they were employed, except they're paying for it now, that it's primary coverage. And this can get them into hot water if they don't realize it and sign up for their Medicare within the proper amount of time, because if the insurer realizes that they should have been secondary and you've used them as primary, they actually can go back and try and recoup money that they've paid out on your behalf. So, and also retiree plans tend to look sometimes, not always, a lot like your active employer health insurance. But again, they're not current employer coverage, and you don't have a special enrollment period if the plan should terminate or you want to leave it. You don't have, well, you'd have an SEP if the plan actually terminates. There are special rules, but if you were to leave that plan, there's no SEP attached to that. Okay, and okay, I think that's it on enrollment. Next slide. Okay, so how to enroll. So when you're in your initial enrollment period, the easiest way to apply is to go online and to go to the Social Security website and enroll in Medicare. You can enroll in both Part A and B, or just A. Let's say you have that employer coverage and you're just going to sign up for Part A and you don't have an HSA that would complicate life, or both A and B. And it's very simple. And you don't need to sign up for your Social Security benefits because, again, 65 is the age for Medicare, but it is not the full retirement age for Social Security these days. So when Medicare started, Medicare and Social Security had the same date for eligibility in terms of the Social Security being full retirement. But now, currently in this year, we're talking it's 66 and 2 months or so, and it's gradually going to go up until eventually the full retirement age is 67 for Social Security. So you don't have to take Social Security when you take Medicare. And signing up on the Social Security site allows you to just sign up for Medicare if that's what you wish to do. It's pretty straightforward and simple. So that's the best way. You could call Medicare and you could get them to take your enrollment on the phone. If you do that, please try to make sure you get the name and the date and the time that you spoke to them so that you have a record, and try and get a confirmation number if you can, because you want to make sure that everything is done correctly. When you do it online, you're going to get a confirmation number. It's really the easiest way. or in person, but unfortunately right now, given our COVID-19 situation, the Social Security offices are closed to in-person visits. And so that's really not an option at this time. When you start moving beyond the initial enrollment period, and we're talking about the special enrollment period because you've delayed because you were working, it's not really an option to do the online because you have to submit 2 different forms, which you can upload online. You can send them over or fax them over. You need to fill out a CMS 40B to apply to get your Part A or B during this special enrollment period, and also a form called the CMS L 562, I think. I'm not looking at it. I apologize. But that is one that your employer needs to fill out, explaining that you've had coverage throughout the time period when you were 65 and older and did not sign up for Medicare. They need to let Social Security know that you've had the appropriate coverage and are entitled to that separate special enrollment period. So that's a little bit different. Okay, now just to make things more complicated, enrollment in Medicare Part C or D. So when you have your initial enrollment period or your special enrollment period, you may wish to choose Part C as your choice in how you're going to get those A and B benefits after you have signed up for the A and B benefits. Or you may want to sign up for a Part D plan for the drug coverage. But you don't do that through Social Security. You do that through Medicare. So you're either going to contact Medicare, either doing it directly with Medicare, you can call them, or through the plan directly. So you can go online on Medicare and it'll show you plans, and you can actually go through their website to apply online, or you can go to the plan's website to apply online, or you can again use your phone, or in the cases of these 2 parts, you could even do a paper application if you wanted to do that. So the takeaway here is that A and B, your foundation, the benefits you're going to sign up for, in order to move into choices about C or D, that's Social Security. And then C and D, that's through Medicare or directly through the plan. Because remember, C, private providers, likewise D, the plans have private providers that have contracted with Medicare. Next slide. Okay, so I'm sure that was not entirely clear and there might be some questions. I don't know if we're gonna, I don't have a chat box, so I can't see if there's any questions at this point about enrollment. Are we gonna do that or not?
We have no questions at this time.
What, no questions at this time? Okay. All right, the next slide. Okay, so Medicare Choices, and we've touched on this a little bit. You can, you would sign up for original Medicare Parts A and B with separate prescription drug coverage if you wanted drug coverage. And remember, if you don't sign up for Part D, you would have a penalty later. But anyway, Parts A and B, and then you could get your drug coverage through Part D. Or you could sign up for Parts A and B and then choose to enroll in Part C with prescription drug coverage included. So those are your coverage choices. Some people do choose to stay with original Medicare, and we'll talk about the differences. And other people choose to sign up for a Part C Medicare Advantage plan as a way to get those A and B benefits that they've signed up for. Next slide. Okay, so let's talk about what these parts contain. And hospital insurance. So I mentioned that any of the medically necessary services that you need in the hospital, Those are covered under Part A. We're talking about inpatient, and it's important to understand what that means. It means you were admitted. Sometimes people get confused because they come in through the emergency room, which is an outpatient service, and then perhaps the physician who is tending to them says, you know, I think we need to keep you overnight. I want to make sure, I'm not sure what's going on, and I want to keep you overnight. And then they keep them for observation. And observation is not an inpatient status. It is an outpatient service. And so there's a lot of confusion sometimes about that. And it's treated differently because when it comes to the cost of that care is treated differently under Part B than it is under Part A. And things have gotten so that there are rules now that try to help patients be clearer about their status so they're not kind of taken by surprise. There's notice that has to be given within a certain period of time if you are on an observation status versus being admitted as an inpatient. Skilled nursing facility care requires a 3-day admission. Again, we're going back to that concept of being admitted before you're entitled to that particular benefit. So you need a 3-day admission, and then you may need skilled nursing care when you're released from the hospital for recovery and rehabilitation. And it's, of course, not long-term care. And you have a 100-day benefit period for skilled nursing care, but generally people are not in skilled nursing for 100 days. And as it gets close, if you get there, then there is going to be a conversation and a need to discuss what's next in terms of long-term care, hospice, whatever that might be. Your hospital benefit period, and we'll talk more about that when I get to the costs, is a 90-day period, and it renews when you have a 60-day break in care from hospital and skilled nursing. Sometimes you need some home health care when you leave the hospital or the skilled nursing facility. Home health care being similar to skilled care, meaning, for example, you need some physical therapy. Maybe you were in skilled nursing and got some and then are going home and need more, and you're not ready to go out to a facility to get that care. Or maybe you skipped the nursing facility altogether, but you are home and you need to have someone come to help you because you can't go out and get the care, and other things coming in to check other important issues that are going on that require some skilled services at home. That's covered also under Part A, and is a good benefit. Blood, the first 3 pints of blood are not covered by Medicare. I don't know why that is, but that is what it is, unless you have donated, and then it's a different situation. But blood after the first 3 pints is covered by Medicare, and it's covered under Part A. And then there's a hospice benefit under Part A, which is with a 6-month terminal diagnosis, and it provides for care for people checking in on you to make sure that you are comfortable. And it's not caregiving, but it does provide a benefit for a respite for your caregiver if it's needed, a short respite. And so it's a good benefit. If you sign up for hospice and you decide you're not going to have further treatment, you just want comfort care, then you can change your mind and get out of hospice. If you live longer than expected, you can get recertified. So it's a flexible benefit, and it's an excellent benefit that Part A provides. Next slide. So outpatient. So again, I stress your doctors are always going to be covered under Part B. And outpatient procedures, which these days are many. You know, there are so many surgeries that are done on an outpatient basis, you know, arthroscopic surgeries, cataract surgeries, it just goes on and on. Many, many services are outpatient these days, and those would be covered under Part B. Laboratory tests, those would be covered under Part B. And medical equipment, medical equipment, wheelchairs, walkers, nebulizers, things like that, and ambulance services. And I always like to comment about ambulance services because at HICAP, we do tend to see ambulance appeals, and we try to help people with them. And that is because the benefit is really pretty restrictive. Under Medicare, you can't just call an ambulance for any old reason. It has to be either a life-threatening emergency or you cannot be moved in another manner that would be safe. And so one should never question whether they should call an ambulance if they think they need one, because we want to make sure that we're okay and we get to the hospital alive. But they do create problems a lot of times with how they're written up by the people who are attending to us. You know, the paramedics are concerned about you and maybe a little less about how they're writing up their report for billing purposes. And even when you get to the emergency room, the staff is concerned with your well-being. And so sometimes the paperwork just doesn't match up with what really was the situation. And sometimes an appeal can help straighten that out. So just a note on ambulances. And then diabetic supplies are also a Part B benefit. I want to make one more comment before I move on this. So most vaccines these days are covered under Part D, but there are a few covered under Part B, and that is your flu shot and pneumonia shot, and also for certain people with certain risk factors, hepatitis. But otherwise, like specifically the shingles vaccine, that is covered under Part D. And so people often think that their vaccines are all covered in the doctor's office, and the doctors often like to tell people they need vaccines, which they do. But sometimes it creates billing problems because they aren't appropriate under Part B billing. Next slide. Okay, so Medicare Advantage plans, Part C. So these plans are provided by private companies that contract with Medicare to provide the A and B benefits. And I've said that a few times since we started. And they can also provide prescription drug coverage, which these days most of them do. The plans renew their contracts with Medicare annually. So every year, these plans have to go back to Medicare to get approval to continue to provide their plan. And it's also a time when they go back to Medicare that if there are changes they wish to make within their plan, they're able to do that. Like perhaps they want to change some of their copays, or they have some additional benefits that Medicare doesn't provide, and they want to kind of tweak those and change them a little bit. Or maybe their premium for their plan is going to change. And so when they renew, this is a time when if there's going to be changes made, generally that's when they're going to make them, when they have to. Or they might change the formulary on their included drug plan. And that would be something that needs to be done at the time that they're renewing. They need to provide everything that original Medicare provides. That's why I always say A and B is the foundation. First of all, you have to have both parts to get into to choose Part C. And second of all, the plans must include all those benefits I was just talking about under A and B. So if A and B covers it, Part C has to cover it. But they can provide extra benefits, and they do. It's their choice which ones they want to provide. But for example, Medicare doesn't cover dental care. And so they may provide dental benefit. Or Medicare doesn't provide routine eye care. So they'll provide care for your eyes if you have a problem like cataracts or glaucoma or macular degeneration. But if it's just about getting your eyes checked because you need a pair of glasses to drive or to read, that's your problem, usually under Medicare, because Medicare doesn't cover it original. But these plans may cover that. Acupuncture is something that might be covered. Routine foot care, because Medicare only provides foot care for people with diabetes generally, routine kind. And so there are a number of things that they might provide that your original Medicare doesn't. So to be enrolled, you have to be an A and B, and you cannot have end-stage renal disease. Now, that is changing. End-stage renal disease has long been excluded from the Medicare Part C plans. If you develop end-stage renal disease when you're enrolled in a Part C plan, they can't ask you to leave, but they have not been able to accept you into a plan if you had end-stage renal disease up until now. But in 2021, next year, that is supposed to change, and end-stage renal will be allowed to enroll in a Part C plan. You cannot use your original Medicare when you're enrolled in a Medicare Advantage plan. This is important to know, because a lot of times people think it's okay. It's like, well, I've signed up for Part A and B, and Part B has a premium, and I'm paying it, and I'm paying to be in this Part C plan. So by golly, if there's a doctor I want to see who doesn't take this plan but takes original Medicare, I'm going to go see them. I should be able to just use my A and B, but you can't. You sign up for these plans, you're agreeing that this is how you're getting your A and B benefits. And to go outside the plan and outside a network that the plan has, unless it's a PPO plan, which allows you to go outside of its network and charges you more, you would have to get the plan's permission. So, which might or might not be allowed depending on the circumstance. And finally, also very important to know is that the plans differ by which county you live in and generally have network providers. So what you have in Santa Clara County is not the same as what people might have in San Mateo County or San Francisco County or in Santa Cruz. So it's different by county. And even when we talk about a plan that is in more than one county, for example, I believe Stanford has a plan both in Santa Clara County and in San Mateo County. And in this case, I think actually their premiums are the same. But some plans that are in different counties, even though they're the same provider, they may charge different copays, different premiums. They may be different even though you think they're the same. And I use this example not because I'm trying to promote anybody, because we don't promote anybody, but I know for a fact that at least in years past, if you lived in Los Angeles and you joined Kaiser, which has a Part C plan, they didn't charge a premium to people to be in that plan. But in San Mateo County, they have always charged a premium, at least in the 10 years that I have been working with HICAP doing this volunteer work. So different counties, different plans. Next slide. So here's another thing to help clarify the difference between Medicare Advantage plans and original Medicare. So original Medicare is a fee-for-service plan. That means that when you see a provider who takes Medicare, that bill for services, the fee for that service or services, are sent to Medicare. And Medicare pays or doesn't pay those bills. They pay those bills based on the rate they have set for that service. They meaning Medicare. So Medicare sets what the deductibles are, what the copays are, and then it will pay those bills based on its agreed amounts on a fee-for-service basis to the provider. Original Medicare, you can use any doctor that takes Medicare anywhere in the United States. So it travels with you. It travels with you. Now, Medicare Advantage is different because you are signing up with a private provider who has a contract with Medicare to give you the A and B services. And in this case, Medicare doesn't pay for the services that you get the way it does in Original Medicare. It pays the provider, it pays the private provider a per capita amount, an amount for each beneficiary that plan is covering. And the plan is what sets its own copays and deductibles, which is what it has to submit for approval to Medicare each year. They have to agree, Medicare, that this is not unreasonable. But the payment arrangement's different. So Medicare Advantage, payment goes directly to the provider for each beneficiary. And Original Medicare, it's fee for service. And again, Medicare Advantage are county-specific plans. And aside from just being different depending on what county you live in, they have limitations on the plan service area unless you have an emergency. So it doesn't do what Original Medicare does, where you can see any doctor that takes anywhere in the United States. It lets you see people within its network within a particular geographic area, unless, of course, you have an emergency. Because if you're traveling and you go someplace like, New York to hit all the Broadway shows, which unfortunately are also not really open right now, and you had an emergency, heaven forbid you had a heart attack, the plan would need to make arrangements to cover you, even though you're outside its geographic area, since you live here in California in one of the counties where they have a plan. Next slide. Okay, so talking about the costs of Medicare. So I mentioned that Part A, most people have no premium because they've paid into the system over time. They've paid FICA taxes as they've been working. And so if they have 40 quarters worth of credits or about 10 years of employment where they paid into FICA, they're not going to pay a premium for Part A. If there is someone who actually doesn't have enough credits, they can still enroll, but if they have less than 30 credits, this year in 2020, they would be paying $458 a month to have Part A. And if they had at least 30 credits, up to 39, but not 40, they would pay $252 to have that coverage. But most people have worked, paid into FICA, and get that with no premium. Part B has a premium. And currently, the base premium for that is $144.60 a month. That said, not everybody pays just $144.60. There's a thing called IRMA, the Income-Related Monthly Adjustment Amount. And this is an additional amount that people who are considered high-income earners are required to pay for their Part B premium. So you can see my little asterisk. If, as an individual, your income is over $87,000, then you will have IRMA. If, as a couple that files jointly, you have income that's over $174,000, then you also are going to have IRMA. And there's a scale, there's a number of different IRMA categories, and they go up, 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 and it increases depending on where you fall on the chart.
Okay, so original Medicare, what other costs do you have? Oh, and I skipped over Part D. So Part D also will have a premium. The private provider will set a premium, also has to be approved by Medicare. And there's a separate IRMA for higher income earners on Part D as well that is added on to whatever premium the provider sets. So, so when we look at original Medicare, you'll see that A and B will also have deductibles and copays, and we'll look at what they are specifically. And that if you don't want to have deductibles and copays, if you would like to take away some of that, then you would have a Medigap policy. And that is a private policy that is designed to cover some or basically all of the deductibles and copays associated with Part A and B. So other costs, you'd have your premium for Part B, a premium for Part D, your IRMA if you're a high income earner on both B and D, and then you might want a Medigap policy, in which case you would have a premium for that as well, if you were using original Medicare to get your benefits. Now, for those people who have chosen Medicare Advantage, again, they still have to pay their Part B premium, and they will still have IRMA if they're a high income earner. And since the Medicare Advantage plan includes Part D, the premium that the plan sets, because you'll have a premium for that plan usually, will include some aspect of it as covering for the Part D. Now, that said, not every single Part C plan charges premium. I mentioned that years ago in LA, Kaiser didn't charge a premium. And I know this year there are some plans that I have seen that actually don't have a premium. So some don't, but generally most do. So you would have that extra premium for Part C in addition to your Part B with IRMA, and you wouldn't have a separate Part D premium, but you would still have a Part D IRMA attributed to you if you were a higher income earner. Okay, so, and the Part C plan would have deductibles and copays, and they vary by plan. So remember, under original Medicare, your copays and deductibles are set by Medicare, and they're consistent. And under a Part C plan, depending on what the plan sets up that gets approved by Medicare, these amounts can vary. Next slide. Slide. Next slide. Thank you. Okay, income-related monthly adjustment amount, we've already touched on it, but I wanted to tell you that it is based on something called a modified adjusted gross income, or MAGI as we call it. That's what's used to determine whether you're a high income earner, whether you fall in these categories. And not being an accountant, I had to look it up, but modified adjusted gross income is adjusted gross income with tax-exempt income and certain deductions added back in. So when Medicare is looking at this, they are trying to bring in as much into the income picture as they can. And so they use this modified adjusted gross income. So an example is if you're getting Social Security benefits, not all of your Social Security is taxable. It also depends on your income bracket, how much is. But that part which is exempt from taxation of your Social Security benefits is included when they're looking at the modified adjusted gross. And they do this with a 2-year look back, which is important to know. So they have a direct line to the IRS. And so they're going to go back to the IRS to find out the last tax return that you filed, what was your income on there? What were the numbers there? And sometimes it's a problem because people will retire, and often when people retire, their income might go down. maybe they're not getting that salary anymore that they were getting when they were working. And so it seems harsh or difficult when they look and they see, oh my gosh, I have this very large additional amount being added to my Medicare premiums. And so there is a way to address that if you feel that your income is not what it used to be. And that is called the SSA, Social Security Form 44. And you can get this online. And it's a form that is for reporting a life-changing event in order to have your income-related monthly adjustment amount reduced or removed. So events are retirement, things like divorce, death of a spouse, things like that, that are considered, and it lists them all on the form what they are. It is often granted, but do be careful to try to be accurate about what you think your income really is right now. Because if you're wrong, they will come to get that IRMA back from you. So it's important to be as accurate as you can. And they do want you to support your request with documentation. Sometimes you have a new tax return. Sometimes you might not, and you just have to attach a declaration, which they will usually honor. But again, they'll go back to the IRS, and if it turns out your income was not in line with what you said, they will come back to get it. Okay, next slide. Medigap plans. So Medigap plans are the thing that I mentioned that will supplement original Medicare to cover some or all of the deductibles and copays associated with Part A and B. Okay, so they do not work with Medicare Advantage. They're strictly for original Medicare. They're sold by insurance companies and they're not a part of Medicare, but they are regulated by federal and state law. And there are 10 of them, and you have the best opportunity to buy them, a guaranteed right, within 6 months of the effective date of your Part B. So when your Part B starts, you have an open enrollment period for a Medigap at the best price with no medical underwriting. In other words, they can't look at your health. They are just going to look at your age, and there are some other factors, and where you live, and they're going to consider some other factors possibly to see if you might get some additional discounts, like are you married? I'm trying to think of what the others are, but are you a woman? I know that sounds wrong, but they do still seem to favor that sometimes. And so that's the best time to get it. Otherwise, beyond that open enrollment period, you may be subject to medical underwriting, and you could be denied coverage. Now, I want to go back to where my little asterisk is about deductibles. So I say some or all of the deductibles and copays. So this year in 2020, things have changed a little bit with regard to Medigap plans. So there was legislation which provided that no longer can these plans cover the Part B annual deductible, and we'll look at that in a minute. But this is for people newly eligible to Medicare. So there were two Medigap plans that covered that deductible. And those plans are not available for people who are newly eligible to Medicare. And what that means is people who turned 65 after January 1st, 2020. So if you're one of those people, then you can't buy these two plans, which we'll look at in a minute or so, because they cover that annual Part B deductible. And the concept is that they were trying to get more cost sharing. When I say they, I say Congress and the legislation that enacted this provision. The concept was, if there is first dollar payment by beneficiaries, then it will possibly reduce what they perceived as unnecessary running to the doctor to check out something that maybe normally they wouldn't, you know. But anyway, that's the rule. That's what happened. So I want to talk also now about the fact that you can, in California, if you're under the age of 65 and you get Medicare due to disability, get a Medigap plan, generally speaking. The law provides for it. So the federal law does not provide for people under the age of 65 with Medicare due to disability to get a Medigap. But California has broadened the law, which they are allowed to do, and they have made it so that people age 65, under age 65 can, in fact, get one of these plans, but not, again, if you have end-stage renal disease. And as far as I know, with regard to Medigaps, that isn't changing, as far as I know. Changing as to Medicare Advantage plans, but not to my knowledge as to Medigap plans, which again are not a part of Medicare. They're private insurance policies. Okay, and if you buy one at and you're disabled, they can consider your health. They can consider your disability. So consequently, these plans can be quite expensive. If you don't buy them within an open enrollment period, which again relates to the effective date of your Part B, you could be denied based on your health. And so that's kind of the general scope of these Medigap plans. Next slide, please. Okay, so these are the things that the Medigap is covering. These are the actual costs that we're talking about when we talk about original Medicare, which is what Medigap plans help pay the copays and deductibles for. So, Part A, hospital coverage, you have a thing called a benefit period deductible. And in 2020, that benefit period deductible is $1,408. And benefit period deductible means it could happen more than once in a year. It could. And this is how it works. So you have a 90-day hospital benefit period. And the first 60 days of that benefit period are covered by $1,408. That applies to 60 days. And those days don't have to be consecutive. So you go in the hospital for a week and then you go home. But you come back 2 weeks later, and maybe it's for the same reason, maybe it's for something else. They count the next day. So you're there for another week, they count another 7 days. Now you have 14 days toward the 60 days that this $1,408 covers. And you can go in and out, up to 60 days with this amount covering your hospital care. However, the way it can start again is if you have a 60-day break in care. So now you go in the hospital and you're there for a week. And you go home and you are very happy going about your business. And on day 61, out and about, you suddenly have to go into the hospital. And you go back in, and now you've been out of hospital care for 60 days. And so you again owe $1,408. And that amount attaches when you're admitted. So you owe it whether you use the full 60 days or you only use a portion of them going in and out without a 60-day break in care. So that's one of the things that people like to have covered by a Medigap. Not all the Medigap plans cover that particular benefit, but Some of them do. Now, this annual deductible, that's been the issue for eliminating two of the plans for newly eligible Medicare beneficiaries, is this annual deductible, which is currently $198. So now, if you are newly eligible to Medicare, that is, you are 65 after January 1st of 2020, or if we're talking about a disability individual, we're talking about a person who gets their disability effective after January 1, 2020. You cannot enroll in the two plans that cover that deductible. They happen to be two plans called C, not to be confused with Medicare Part C, and F, and we'll look at those in a minute. So you cannot sign up for those plans because it covers this deductible. And Congress said, that's a no-no, no more coverage for newly eligible beneficiaries. But if you are someone who turned 65, let's say, before January of 2020, and maybe you've delayed Part B because you have employer group health coverage, you are still eligible to enroll in those plans. Those plans can be sold to you even though they cover the annual deductible. So if you were 65 before January 1st, 2020, you still have a right to those plans. And similarly, if with respect to disability, your benefits were retroed into before January 1st, 2020, again, you have this opportunity to buy those plans. And of course, anyone who's currently in those plans can stay in those plans. Okay, other things to be covered by the Medigaps are days 61 to 90 of your 90-day benefit period. So if you used up your benefit period deductible because you had, in and out, 60 days without a 60-day break in care, you're now on to days 61 and 90. And in 2020, those days would cost you $352 per day, which is quite a bit of money. And so all of the Medigap plans, as a basic benefit, do cover days 61 to 90. So if you buy any of the Medigap plans that are available to you, it will cover that particular copay. Lifetime reserve days, you use up your full 90 days. No 60-day break in care. Got to have a 60-day break in care if you want to renew your 90-day benefit period, but you didn't, you're really sick, didn't happen. Now you move into your lifetime reserve days, and these are 91 to 150. So you get 60 lifetime reserve days. And those days, if you use them, will cost you $704 per day in 2020. That's what they cost. And if you use one of those lifetime reserve days, once you've used it, it doesn't renew. It's gone. So use one of the 91 to 150. Now you only have, 90. So anyway, that's how that works. And that also is a basic benefit that all of the Medigap plans are going to cover. Skilled nursing days, remember 3-day admission to the hospital, and then you're entitled to a 100-day benefit period for skilled nursing, which you may or may not qualify to have because you may get better sooner than you think and be asked to go because your time is up. But in any case, the first 20 days are paid for by Medicare. Medicare pays for those first 20 days of skilled nursing care. And then 21 through 100, you have a copay, and that's going to be $176 per day. So that's that could add up if you're there more than 20 days. And then hospice care, it takes care of the any copay or coinsurance. And basically hospice care, the only thing you're going to have there is a copay of not more than $5 for prescriptions needed for your hospice care. In other words, medications that are to keep you comfortable. Those medications are part of the hospice care benefit, and you would pay no more than $5. And then the coinsurance would relate to if you need respite as the caregiver or because the caregiver, whomever it may be, needs to have respite, and would allow you to utilize hospice care within a hospice care facility, and that you would have to pay no more than $1,408. It would be capped at the benefit period deductible amount. On the Part B side, a little, easier, a little less information. You're talking about a 20% of whatever the Medicare approved amount was for your outpatient service with your doctor. And so if the approved amount's 100, Medicare is going to pay 80 and you pay $20. And so that's how that would break out. And that 20% is a basic benefit that all the Medigap plans cover. Now, some Medicare providers do charge more than the Medicare approved amount, but they can't just charge anything they want. So they are limited to charging no more than 15% above the Medicare approved amount. So if Medicare were to say it's a $100 service, Medicare would still only pay $80 toward that service, but you would have to pay the additional 20%, the $20 plus the extra $15 that the excess charge allows. So some doctors charge that, and this is not in the basic benefit category for the Medigap plans. This is something that only some of them cover. But the 20% is a basic benefit. So these are what your costs with Medicare look like. Your costs for the services for your fee-for-service original Medicare, not including anything you're paying for your Part B premium or a Part D premium. And the Medigaps don't work with Part D, so they only cover things that are covered by A and B. Next slide. Okay, so here's what, these are the plans. So the ones that newly eligible beneficiaries cannot buy are C and F. And those plans, F has long been the most popular plan because it covers everything. Everything that you could get a bill for that is approved by Medicare as medically necessary, it pays those copays and deductibles. But again, because you can no longer have Part B deductible coverage, that plan can only be sold to people who were 65 or disabled before January 1st of 2020. And Part C also covered that. You'll notice on the chart, it did not cover that excess charge, that 15%, but that's not the reason it was eliminated. It was eliminated for newly eligible because of its coverage of the Part B deductible. And again, it is a plan that people who are not newly eligible can still get. Okay, you'll notice Plan A, not to be confused with Part A. This is the plan that covers only the basic benefits that I was pointing out. So it pays for those expensive days in the benefit period, the ones 61 to 90 and 91 to 150. One thing that these Medigap plans all include are an extra 365 days of hospital benefit, lifetime days. And so Part A also covers that 365 days after you've used up all your Medicare benefits. You have access to this 365 days if you have Medigap, if you have any of these Medigaps. Part B, again, the 20% is covered because that's basic. And the first 3 pints of blood are covered, because remember I said they're not covered usually unless you've donated blood, they're not covered. But under the Medigap, they're a basic benefit and all the plans cover that. And then the hospice benefit also is something that all the plans covered. So those are the basic benefits. And A has the basic benefits. And all the plans must contain the benefits that A contains. So if you're going to sell a Medigap, you're an insurance company, you will sell A, and then any other plan that you might sell is also going to contain the A benefits. And you can sell other plans, but the rule is that if you're an insurance company and you want to sell something besides A, you need to sell C and F to those people who still can get it. It has to be available. Or now the plans that you have to choose from to sell if you want to sell another is G and D. Okay, so finishing along here, you can see what benefits are covered by some of the plans, but not all. Your skilled nursing is not covered by A or B, so that $176 a day after your first 20 days is not covered. The excess charge isn't covered by everybody. And another benefit that some of the plans have, but not all, is foreign travel emergency benefit. And that is, Medicare does not cover foreign travel emergency. It doesn't cover any medical services when you're outside the United States. Under the fee-for-service, I have to say that the Medicare Advantage plans, many of them do cover foreign travel emergency, but it's a very small amount, and I wouldn't recommend that anybody go traveling abroad. Well, probably not too much travel abroad right now anyway, without having, travel insurance, because it's quite limited. It's in the first 2 months of travel for an emergency, after a $250 deductible, and I think the lifetime amount, I may say this wrong, I think it's only $50,000, but I could be wrong on that. So I apologize if that's not entirely accurate. I just wanted to focus on a couple of these plans that you see that have some different numbers in them. So there was a push to try and, again, get more cost sharing, and this has been quite some years ago now. And so K and L were introduced, where the beneficiary who buys one of these plans would have to pay some of what's covered. So in other words, Medicare under K would only pay 50% on the 20% copay. So they're still including that, but only at 50%. And under the L, Medicare would pay 75% of that copay, and so forth. Another feature of these plans that have this cost sharing is that they have an out-of-pocket limit, which the others don't. And that means that if under K, your out-of-pocket were to reach $5,880 in 2020, then that plan would pay 100% for the particular benefits that they cover. And on L, it would be $2,940 out of pocket, and then the plan would pick up 100%. So those are two plans that are quite different from the others. And then you have M, which is more like the others, but has just on that Part A benefit period deductible, it only pays 50%. And you could see it doesn't cover the excess charges. And then N, which is a plan that has become pretty popular, particularly for people who are concerned about costs, because even when you buy these under the open enrollment period for the Medigap, they can still be expensive, and the cost goes up. I mean, the cost goes up regularly. Most of them are based on attained age, and it will go up based on you being older, but they can also raise their rates at other times due to other factors like inflation. So these plans can be a little bit costly anyway, but N has gotten popular because it covers pretty much everything. It doesn't cover the Part B deductible, and now for newly eligible, that can't be covered anyway. I mean, it doesn't cover the excess charge, but it does cover the rest of the stuff at 100%, and it has a little slight tweak to when you go for an outpatient visit to your doctor, and that is you would pay $20 as a copay for an office visit. And also, if you go to the emergency room, you would pay $50 for the emergency room, and if you were admitted to the hospital, that $50 would be waived. So it's still got a lot of coverage, and premium-wise, it has typically been less expensive than, for example, Plan F that has been very favored by people that covered everything, and now the place of Plan G is moving into that space that, F was in, where it's the one that's going to cover the most benefits. So those are the Medigap plans, and the chart pretty much says it all, and I hope I've explained it well enough that you are clear on some of the differences between the plans and what you can and cannot have. Next slide. So there are some programs that help people who are low income, and we do help at HICAP. We help people to enroll in these plans. We help them to understand what they're about and to try and help them get enrolled. MSP is a Medicare savings program, and one of these programs will cover Part A premium if people's income meets the required limit for people who have to pay a premium for Part A. And that plan is called the Qualified Medicare Beneficiary Plan, or QMB. And it also then will pay the Part B premium, and it will pay the copays and deductibles for Part A and B as well. The QMB plan will. But there are another couple of plans. There's the specified low-income beneficiary and the qualified individual that are part of this MSP program. And in those cases where your income might be a little higher than is allowed for QMB, those plans will pay the Part B premium for people who have a low income that meets the required limits of those plans. So these are very helpful to people who are low income, and we can help people look into those plans. LIS is known as Extra Help, and basically when you enroll in Medicare, you are likely to receive something that says, do you want to sign up for this? They send you an application. We help people fill out applications as well. And what this does is it helps to pay some or all of the Part D premium that you might have. And it provides that you will have no deductible, low copays, and no coverage gap or donut hole. So these are very helpful plans also. Interestingly, MSP is a plan that goes through Medi-Cal for application, and LIS is something that is handled through Social Security. And both of these are helpful for low-income people. There are other programs too, but given that we probably don't have a lot of time, I'm not going to get into those, but we can help people with those. There are some others. Okay, next. So retiree plans. I wanted to touch on these because some of you may have that option. So retiree plans are all different. The employer who provides a retiree plan can pretty much do what they want when they set up their plan. So each plan has to be looked at as itself. If people come in for counseling and they have one, we need to review the plan summary to see what it's all about and how it works with Medicare. Now, some plans coordinate with Medicare, many, and some do not. So if it coordinates with Medicare, then you would need to sign up for Part A and B. So I'm going to use an example because I can think of one. So TRICARE for Life for retired military coordinates with Medicare, and you need to sign up for Part A and B. But on the other hand, federal employee benefits can coordinate with Medicare. They like you to sign up for A and B, but you're not required to sign up for A and B. So that's just an illustration of how plans differ. And then VA benefits, if you have those, they don't coordinate with Medicare at all. They're two separate things. You can have Medicare, you can have VA. I don't know what happened here. Oh, no. And so I'm having a problem here with I can't do this. So they're all different. And then I don't know how to get rid of this thing on my screen, and I don't know if you guys can see it or not, but I can't get rid of it. Okay, and so Part D coverage is it may or may not be part of a retiree plan, but you want to make sure if you are in a retiree plan that the coverage is creditable, because if for some reason you were to leave that plan and want Part D coverage, you would be in a position of having a penalty. And I'm pretty sure I missed that slide. Okay, so it's very important if you have a retiree plan that you check with your plan administrator before you consider enrolling in Medicare Part D. Because if you do enroll in it, it is possible that you would lose your retiree health plan, and not necessarily just the drug coverage, but the entire health plan. So it's extremely important that you always consult your plan administrator before enrolling in Medicare Part D. And when we have a retiree plan, Medicare is always the primary coverage and the retiree plan is secondary. So that's something that's important to know. And when you're doing a retiree plan that coordinates with Medicare, the plan might act as a supplement to Medicare, like a Medigap. In other words, provide the copays and deductible coverage for original Medicare benefits, or it may provide something that's like a Medicare Advantage option, or even an actual Medicare Advantage option, but that has been contracted with so that it has some differences, such as a lower copay on certain services, that kind of thing. So the thing to know, they're all different. Retiree plans are always secondary to Medicare when they coordinate with Medicare, and some, but not all, do coordinate. And you want to look into whether or not these plans have creditable drug coverage, and you want to make sure, however, that you don't enroll in Part D unless the plan allows for it. Okay, next slide. I think we're almost getting there. I don't know if any people have questions at this point, or if we're out of time, or if we're going to save everything till the end. So just let me know if we're moving on or we have some questions. Okay, Part D. So Medicare drug plans. So these plans are like Medicare Advantage plans They are sold by private companies that have contracted with Medicare to make these plans available. Now, unlike Medicare Advantage plans, these plans don't require you to be an A and B. You can have A or B and buy one of these drug plans. So, sometimes people will have one or the other. If someone has to pay for Part A, maybe they've only enrolled in Part B, but they would like to have prescription drug coverage. And if they have enrolled in B, they can go ahead and do that. They can enroll in the drug plan. So Congress, when they started this, when they established this prescription drug coverage, they established a very specific plan design. And every plan that contracts with Medicare to provide these plans has to provide a plan that is in line with the standard plan design. And it can only deviate from that if it happens to provide a better benefit or if it's actuarially equivalent. Those are the two cases where it can look at all different from the standard plan design that was set up. And you need to enroll in Part D to have the drug coverage, but if you have other creditable coverage, then you can actually delay doing that. You don't need to sign up for Part D. So again, I'll use an example. VA prescription drug benefits, if you're eligible for them, they are creditable and you wouldn't have to sign up for Part D unless you lost those benefits. TRICARE for Life has its own Part D plan, and it's not a Part D plan, it has its own drug plan. So, and it's creditable, you don't have to sign up for Part D. So it depends. COBRA, if you took COBRA, if you had COBRA, if you had Medicare before you were eligible for COBRA and was allowed to take COBRA as a secondary, you would have to, as I mentioned, sign up for your Part B within the 8 months, not the 18 months that COBRA would allow you to have COBRA. But for Part D, if the COBRA benefits for drug coverage were creditable, that is, if the employer coverage from which it came was creditable, then you could actually continue with the COBRA for the Part D. Now, usually you have to keep all of the COBRA, so if you have to start paying for Medicare and being in Medicare, you might not want to continue, but the point is it's creditable and you don't have to sign up for Part D if you have creditable drug coverage from COBRA. The premiums are all over the place. There are handouts. I have been kind of speeding along because of our unfortunate delay in getting started, but there is a sheet which shows you the many prescription drug plans that are available. And when you look at that sheet, you'll notice there's a column that tells you what the premiums are for those plans. And they're all over the place. I mean, they're as low as maybe $19 or $20 and as high as $100 and something. So they vary greatly from plan to plan. And you can't pick a plan based on its premium. Just that's not doable. And aside from that, you'll also notice on the sheet, if you look at it, that there are plans that will have a deductible. Most of them do, because that relates to the standard plan design, which we'll look at, and some of them don't. And then you see a bunch of tiers that have different co-pays or co-insurance, and you'll see they all differ completely. And remember, your Part D premium for whatever plan you pick is going to have that income-related monthly adjustment amount if you're a high income earner. Over $87,000 as an individual, over $174,000 as a couple filing jointly. Next slide. Okay. So, there we go. So there are 4 cost structures in the Part D plan structure, and that is the deductible, the initial coverage, the donut hole, and the catastrophic coverage levels. And at each part of the program, at each structure level, the cost of your drugs will differ. And so you don't have a consistent drug cost throughout the program, although, well, I'll get into that after. But so it's different at each point. The plans themselves are only required to cover 2 drugs in every class and category. So the drugs differ by plan. Medicare has a huge formulary. What each plan picks to put on their formulary will differ. And so you really need to look to make sure the medications you take are on the plan you pick. Because if you sign up for one that doesn't have it, you're going to end up having to ask for an exception, and maybe you'll get one and maybe you won't. And if you do, it's going to end up being more expensive because it's not on the formulary. So the plans also can place restrictions on the particular drugs on their formulary, and these restrictions are prior authorization, step therapy, and quantity limits. So quantity limits speaks for itself. It's the standard amount of medication of that particular type that is generally prescribed. If it's an odd dosage amount, an odd frequency, then you may need to seek an exception if your plan has quantity limits and you are not within them. Step therapy is when they tell you, take this drug first, and if it doesn't work, well, then take that drug, and then if that doesn't work, okay, well, then this other drug that you really want is the one you can have. And so, again, when you're looking at plans and you're thinking about which one to enroll in, you're going to look for the one that covers your drugs. Then if you can find one that's economically priced that has your drugs but doesn't have step therapy for the particular drug you want, and another one does, you probably want to go with the plan that doesn't require the step therapy. Again, there's exceptions that can be made. Your doctor may say they're allergic to this other one, or we've tried all of those, and you might be able to get an exception. But again, then the drug is apt to cost you more. Prior authorization, that pretty much speaks for itself too. It's on the formulary, but they're not going to give it to you unless they agree to do so. And your doctor has to give them the reasons that you need to take this drug and ask that it be authorized. So those are the restrictions that can be on a plan. And obviously, if you can avoid restrictions and find a plan that covers your medications without them, but is still reasonable in price, you might want to do that. So these structures and these rules I've just talked about, they apply to the drug plan even when it's part of your Medicare plan. And then if you have a retiree plan, again, we stress do not enroll in Part D without consulting your plan administrator, because it could cause you to lose all of your benefits. So you need to be careful there. And one of the reasons is some of those plans actually use a Part D vehicle for their drug coverage, and you can't have a duplicative coverage like that. And then the only sensible way to pick a drug plan is to do a Medicare.gov search to find your medications, see which plans will cover them at the best cost and that meet your needs. So you need to do a Medicare.gov drug search. Now, we help people with Medicare.gov drug searches all the time. We're happy to do that. I believe in the handout materials that there is a drug search form that if you wanted us to help you with that, we could do. And even when you're looking at Medicare Advantage plans, you want to know what their formularies cover, because if you're thinking about enrolling in one and they don't cover in their formulary the medication you need, maybe it's no biggie. Maybe you're willing to go for an exception. Maybe you're willing to change the drug you take to something similar. But it's personal, and you have to make a decision about the coverage you need. So even for the Medicare Advantage plans, we do the search to help people see if they're considering Medicare Advantage plans, if the formulary will cover what they take. Now, the question I get asked all the time is, what do I do here? I don't take anything. I'm a really healthy person. I don't need anything. I don't want to have a drug plan. And I have to say to them, well, if you don't have a drug plan, you are going to end up with a penalty if you didn't get it when you could have and should have during your initial enrollment or during your special enrollment period. You need to do that. And so I definitely recommend people still enroll in one. And I say, find yourself a placeholder. If you're not taking medication now, you may be in the future, and you don't want to be having a penalty. And I feel like we didn't see that slide, so I'm just going to say the penalty for not enrolling in a Part D plan when you could have and should have is 1% of the base premium, of the current base premium, for every month you could have, should have, and didn't. And so that can add up. It's cumulative. You know, you go enough years without drug coverage, and your penalty is going to be, it's a small penalty because it's usually the base premium isn't that huge, like it's $30-something. It could be more in the future. But the bottom line is it adds up. And then it might not be worth it to get a drug plan, depending on what plan you need, especially if the premium for the plan you need is not one of the cheapest. So I say pick a placeholder, pick out a plan that's agreeable to you in terms of its premium. You know, it doesn't have to be the cheapest, but it can be one of the cheaper plans that you choose, and just have it in case you need it, because you're going to have a chance to change that plan later on. Okay, next. So this is the crazy structure of the 4 parts. $435 deductible. The initial coverage phase is the plan is going to pay 75%. You're going to pay 25%. And the numbers are such because they're looking at the 435 and then what's left to get to $4,455 because when your 75 and 25 and your annual deductible add up to that $4,455, you've moved into the coverage gap or donut hole. So the main thing to know is that some plans do not have that $435, and you'll see that on your handout. But the truth about it is, if they don't charge you that in the annual deductible, it's going to be made up in the initial coverage phase. It's got to be a better benefit. Maybe it won't be if it's a really better benefit, but usually it's going to move into the initial coverage phase because you have to make it up somewhere. It has to be actuarially equivalent. Anyway, 75-25 in initial coverage. In your case, you're going to be looking at the chart. You're going to be paying some sort of copay, either $10 or $45, or maybe it'll be a percentage like 33%. That will be what is in your pay column and is working toward your 25% of the drugs. So in this phase, you've got the plan paying the bulk, the 75% of the drug coverage. You and the plan hit the coverage gap when together the amount is $4,455 spent. Okay, so the donut hole closed. It's closed now, but there is still a lot to know about it. The goal was to get the coverage gap to have a 75-25% split, just like through initial coverage. But the way that things work, you're still paying, the payment for the drugs is still different, because now on brand name drugs, you have a manufacturer's discount of 70% on the brand name, and then 5% plan liability, which is essentially a subsidy from the government. to make up that 75%. If it's a generic drug, then your plan's paying the 75% and you're paying the 25%. And just to make things complicated on your side, you have to spend $5,018.75 in true out-of-pocket costs before you move into the catastrophic coverage phase. But that $5,018.75 is not quite as bad as it looks because you get credit for the 70% manufacturer's discount, as if that were paid out of your pocket. So it's a 75-25% split now during the coverage gap period, but the way the drugs are paid for, the cost of the drugs is going to look different than when you were in initial coverage. And there is a small dispensing fee on the covered brand name drugs of $1 to $3. And so moving on, just the last phase, catastrophic. Once you have spent that true out-of-pocket cost and your total out-of-pocket threshold of $6,350 has been reached, which is deductible, initial coverage, and donut hole, now the plan is going to pay 95% of the cost of the drug, and your share is going to be 5%, or if it's greater, right, 5%, whichever is greater, or $3.60 on a generic, $8.95 on a brand. So depending on which is greater, you might still be paying a fair amount if you have to pay the 5% if you happen to have a costly drug in the catastrophic phase. Next. I'm next. Next slide. So I'm sure as fast as I went through that probably there are many questions, and we can take them, but I think we're moving on and we'll take them at the end. So now we're going to talk about those open enrollment periods, which is the final discussion, unless you are giving me a question, which I don't think you are. So next slide. Okay, quickly. So we talked about the initial enrollment. We talked about the special enrollment period. And I'm feeling like we skipped the slide that had the general enrollment period, which is January 1st to March 31st, which I need to mention because that is the period where if you missed your initial enrollment period, or you missed your special enrollment period, or you missed both, you would sign up for your Part B during that period. And if you had to pay for Part A, it's a time when you would be able to apply to get it and even file for a QIMBY application to get free Part A, not have to pay for it yourself. So I mentioned the GEP, the general enrollment, it's the general enrollment period because it coincides with one of these open enrollment periods that we're going to talk about. So initial enrollment, special enrollment, you are signing up for the first time for your Medicare benefits. Now you have benefits, but you want to change your benefits. So you have an annual election period, or nowadays called the Medicare open enrollment period. And this period runs from October 15th to December 7th each year. And this particular enrollment period allows you to change your drug plans if you need a different one because it doesn't cover your medications anymore, or it's gotten more expensive for the coming year. You can change it, or you just don't like the plan. The customer service is terrible. So you can change drug plans. You can change your Medicare Advantage plan if you want to change to a different Medicare Advantage plan. Or maybe you want to go from a Medicare Advantage plan to an original Medicare way of getting your benefits, or go from original Medicare to a Medicare Advantage plan. So you can make any changes you want during this time period. And whatever changes you make, they're going to be effective on January 1st. So generally, people have plans and they want to make changes. But if you didn't sign up for your Part D when you should have, then this would be the time you can do that. Or if you wanted to sign up for Part C because you had not done that in the past, you could do it. So this is the Medicare open enrollment period. And you will, these plans, as I mentioned, the Medicare Advantage plans and the drug plans, they are doing, they're going to renew their plans with Medicare each year. So if they're making changes, it's going to happen in conjunction with this annual election period, with this open enrollment period. So before it takes place by September 30th, they meaning Medicare Advantage plans or drugs plans, they will need to send out an annual notice of change to let you know what changes the plan you're in are about to make for the new year. And then you can decide if you don't like those changes or the plans no longer suit your needs. So that is this. Next slide. So now we have an open enrollment period that's called the Medicare Advantage open enrollment period. And this enrollment period is from January 1st to March 31st. So it runs the same period of time that the general enrollment period runs. And this is a time that's different than the one I just discussed, because it's really about changing from one Medicare Advantage plan to another Medicare Advantage plan, or changing from a Medicare Advantage plan to original Medicare, which you can do in the other period as well, and adding a Part D plan. If you're going back to original Medicare, you're losing your Medicare Advantage drug plan, you would want to add a Part D plan. And the coverage in this case, when you make this change, is going to be effective the first day of the following month. So the Medicare open enrollment period in the fall, October 15th to December 7th, that one starts your benefits for the new plan year, January 1st of the following year. But with this plan, you're already in a year, and they will start the change the first day of the following month. Now, you cannot change from original Medicare to a Medicare Advantage plan during this time period. You cannot do that. And under the other time period, yes, you can do that. And really, in both cases, you don't have a right to buy a Medigap plan when you decide, if you decide to go from the Medicare plan to original Medicare. So you don't have a right to buy one. You may be able to buy one. Insurance companies like to sell them, but you may well be subject to medical underwriting, and it could be expensive. You could be denied, or you could be limited as to the Medigap that you want to choose. And that's really true even in the situation of the Medicare open enrollment period, as opposed to just this one. Your right to buy the Medigap plan, as I had stated, is best done 6 months from the effective date of Part B, because that's when you're going to get the best rate. And there are other special exceptions, but that is the general rule about the best time to do that. Okay. Oh, and another thing, one last thing about this. So under the annual election period, the open enrollment for Medicare, you could actually make a change and change your mind and make another change. Not always the best thing to do, but it might happen. Here, when you make a change, that's the change, one change allowed. But please note that if you made a change during the Medicare open enrollment period, the annual election period, and then you're here in January and you have this Medicare Advantage open enrollment period, if you want to make another change that falls within the descriptions on this slide, changing to another Medicare Advantage plan, or changing to original Medicare, you could make another change. But I am not certain that you have a right to add a Part D. Well, you do because you're in this period. So you could do those things. You could still, you're not precluded from making that change just because you made it during the annual election. You can make another choice January 1st to March 31st. Okay. Change, slide. And then this is just an illustration of some special enrollment periods where you're allowed to change coverage outside of the annual Medicare open enrollment period, the annual election period. And basically, we're talking about situations where the extra help, if you have extra help for your drug coverage, once a quarter, you actually can change your drug plan. You don't have to wait for the annual election period. And if you have full scope Medi-Cal, meaning you don't have to pay anything for Medi-Cal to be providing a secondary coverage for you with your Medicare, you also have that same right to make changes once a quarter, even as to your plan altogether. I mean, you could be in a plan, a special needs plan for people who have Medicare and Medi-Cal, which is a Medicare Advantage type of vehicle, specially designed for dual eligibles. Or you could just, you can change drug plans if you have a drug plan you don't like. So same thing. Enter or leave a long-term care facility that gives you special rights to change your coverage. And if you move out of the service area. So again, the Medicare Advantage plans are very geographically specific. And if you move out of the service area of the plan you're in, even if the place you're moving to has a similar plan, you have a right to make a change to your coverage. Non-renewing plans, it happens sometimes. Sometimes Medicare Advantage providers or drug plan providers decide they don't want to do business with Medicare anymore and they leave. And sometimes Medicare decides that they don't want to do business with the particular plan anymore. So it happens that plans may not always renew, and then you would have special rights to make changes to your coverage. And then also if a retiree plan terminates, which sometimes they do. And then the last two things is, one of them, number 8, is what I was discussing about creditable coverage. Maybe you had coverage at the VA for your drug benefit, and the way the VA works, they have a priority system and things happen and suddenly you're not eligible for that coverage. That would be a loss of creditable coverage, and you would be able to, outside of the open enrollment period, the normal open enrollment period, sign up for a Part D plan. And then there's something called 5-star, which is how Medicare Advantage plans and drug plans are rated based on many factors, customer service, safety, different factors about how they're performing. And it applies to drug plans and it applies to Medicare Advantage plans. And I don't know if there's any difference in other counties, but I'm with San Mateo HICAP, and in San Mateo, for certain, the only 5-star rated plan we have is Kaiser at the moment. So that doesn't necessarily mean they're better than somebody else, but it's a rating system which has determined that because they are, in Medicare's eyes, doing a good job, that you can enroll in them outside of the open enrollment period, which normally you'd have to wait to do. We haven't had any drug plans that have met the very strict criteria for getting a 5-star rating. So, and if you do enroll in this special situation, you would have your new plan become effective the following month. And you can do it once during any year from, I forget what the date is, because there's a few days you can't do this enrollment. I think it's from December 8th to November 30th, you can do a 5-star change. And we hope in the future there will be more plans that have ratings that allow people to move to another plan outside of the open enrollment. And I think that's it, except for the last slide. And that's just how we can help. And we hope that you will call on us to help. We provide free, unbiased one-on-one counseling, and we deal with your specific personal situation. So we do the drug searches. We help people who have issues with Medicare or need assistance with appeals, and we help with the low-income programs. We also have some counselors that are able to provide counseling on long-term care policies. There's our number, and please complete the evaluation. I am sorry this was as rushed as it was, and we had these technical difficulties, but all things considered, we pretty much got through it, and I hope it was helpful to you. Thank you. Thank you for being here.